Dr. Philippe Ryvlin. He's a professor of neurology and chair of the Department of Clinical Neurosciences and of the Neuropsychology and Neurorehabilitation Services at the University Hospital of Lausanne in Switzerland. He's also an affiliated professor of multimodal epilepsy surgery evaluation at the University of Copenhagen in Denmark. Dr. Ryvlin completed his medical school and then training in neurology in Lyon, France, at University of Lyon. He also completed a master's degree in statistics and epidemiology, and then a degree in genetics and cytogenetics. He has completed his specialized training in epilepsy at Montreal, UCLA, and Zurich University Hospital. As a clinician researcher, he has developed and co-directed the Laboratory for Integrative and Translational Research in Epileptology during his years in Lyon, and set up the Laboratory for the Study of Excitability in Cortical Arousal Disorders and the Neurotech Research Platform at UNIL. His research work in the field of epilepsy is aimed at better understanding and preventing sudden and unexpected death in epilepsy, SUDEP, one of the most frequent causes of sudden death in young adults, in particular through the development of connected objects for detecting and characterizing epileptic seizures. His research uses mobile health technologies and is being extended to other neurological disorders, in particular migraine. Since 2018, he has been coordinating the development and deployment of clinical research platforms developed as part of the Human Brain Project, including the Medical Informatics Platform and Human Intracerebral EEG Platform. For many of us, he doesn't need any introduction, but for others, he's a very widely published author in the field of epilepsy with more than 350 peer-reviewed articles and more than 20,000 citations. Thank you so much, Dr. Ryvlin, for joining us. It's all yours.
Thank you very much, Neil, for this kind of introduction. It sounds like generated by ChatGPT, at least partly, so it
all
might not be reliable.
All from your website.
Just kidding. Actually, I would like to share with you my current interest for the last 15 years, 20 years almost, is really SUDEP, and that's where I try to focus most of my clinical research energy for what it remains due to my other responsibilities. And I'll start with first showing you where I live. That's how it looks in the winter. It's close to Lausanne, just a few kilometers in the Vineyard. It's a UNESCO classified region called Mont du Lavaux. I hope you'll have a chance to see it once. We organize from time to time epilepsy meeting in Lausanne, so maybe you'll have a chance. You probably all know the definition of SUDEP, so I'm not going to read it. What's important, of course, is that it's not necessarily related to a seizure, even though, as we'll see, a seizure seems to play a major role in the majority of SUDEP. As you understood, indeed, I have some collaboration in Denmark, and I had the chance to work with Marius Klovgaard, who published a few interesting papers recently. In one of them, we could take advantage of all the data set, national data set available in Denmark, to compare what will be the incidence of SUDEP within the global incidence of sudden unexpected deaths. We hear from time to time from zoos occurring on a soccer field, for instance, in person without epilepsy. Well, it happened that SUDEP might represent up to 1/4 of all sudden unexpected deaths. So it's really one major contributor to those tragic events. And when you discuss with bereaved family in the field of epilepsy, I can tell you, because I had the, well, shall I call it the chance, but at least the responsibility of discussing with a number of people who come to me because of my interest in SUDEP to discuss why they have lost their loved one. It's always so tragic event. We need to do something about it. So it's about 25% of all sudden unexpected deaths. And within epilepsy, it's the most prevalent cause of deaths, at least in people below 50 years of age. And as you can see, as compared to status epilepticus, seizure-related accident, or suicide, all of which are, of course, increased as cause of premature mortality in epilepsy, it's the most important one. Now, the global incidence of SUDEP, if you need to remember one figure, it's about 1 per 1,000 patient year for epilepsy in general, and in adult, maybe 1.1, 1.2, but it's around 1. In children, for some reason that we do not yet understand, it largely varied between series, with some of them reported 5-fold less incidence, and that's what we published in the American Academy of Neurology Guidelines in 2017. But since then, there has been 2 studies, including the one performed in Denmark, where we found similar incidence as in adult, 1.1. It's not clear, especially the discrepancy between the Swedish and the Danish one. And I just realized I inverted the 2. So it's a lower figure in the Danish one and higher in the Swedish one. Sorry for that. But behind this general figure, 1 per 1,000 patient year, we know there is a very large variation depending on the epilepsy population. And that was already published 20 years ago, with this difference between the highest incidence, which was close to 1%, and the lowest, which was close to 0. Now, let's move to the risk factor. It's clear that when you interview, again, bereaved family in different series, and this is one of the largest coming from Sweden, the group of Torbjörn Thompson, the majority of SUDEP occur at night at home in the patient bed, and most of the time the patient will be found in the prone position. So clearly, we do have here a situation which is typical, even though it's not found in all the patients. The SUDEP are rarely observed, but when they are, in most instances, a seizure will be observed. And we'll come back to that later on. Majority of SUDEP follow a seizure, but a minority might not be triggered by a seizure. The Swedish study is remarkable because it enabled to perform a case control study at the national level, largely reducing any potential bias in those type of study which are necessarily retrospective. And looking at the different risk factor here, the first one that we all know is, of course, the occurrence of generalized tonic-clonic seizure or focal to bilateral tonic-clonic seizure. We'll use GTCS for both during this presentation. With the greater the frequency of GTCS, the greater the risk of SUDEP. And when you adjust for the frequency of GTCS, you still find other contributing risk factor, not sharing household but not bedroom, unknown type of epilepsy, alcohol dependence, and substance abuse. When you combine the 2 main risk factors, suffering from GTCS and not sharing household or not sharing bedroom, you see that you can have odds ratio culminating to 67, which is huge. A number of other risk factors have been reported. Usually, I will say in isolation, that means not taking into account other potential risk factors and not adjusted most of the time on the frequency of GTCS. And this include heart rate variability. This include changes on the MRI, including like brainstem atrophy, some respiratory dysfunction, periictal respiratory dysfunction, and so forth. But the issue here, which is illustrated by this scheme, is that all those other biomarkers that have a relation with the autonomic system, and that makes a lot of sense, of course, in the quest for better understanding SUDEP pathophysiology and predicting its risk. Most, if not all, of those biomarkers seems to also directly relate to GTCS. So, of course, not adjusting on this major clinical risk factor is likely to provide you with, let's say, spurious findings, or at least association, which will not reveal any causality between those autonomic abnormality and the risk of SUDEP. So we still have to work on those issues. It's an important track of research, but at the moment we need to acknowledge that we are lacking appropriate clinical research study to really ascertain the role of those different abnormality. Now, I'm going to say a few words about a study we hope to publish very soon. It's a study that was started a long time ago, as you see, 2010, so it will have taken 15 years to be published eventually, and I'll explain why. And it's a different study from all those performed so far. It's what we call a prospective study with a nested case control analysis, which means that from the beginning, we start by including a population with a view to look at SUDEP risk factor, but all patients are alive at the time they are recruited. Actually, in that particular study, they are recruited in the EMU when they start a pre-surgical evaluation, and then they are followed long-term until, unfortunately, some of those patients have died of a SUDEP, and then we can look at the data and comparing those patients from those who did not die from a SUDEP. Clearly, you can reduce the bias of the classic retrospective case control study by doing so. And you probably know that Sam Latu, who worked at your institution in the past, did exactly the same study in the US within the NIH Center Without Wall, and shall also publish his finding very soon. So we had recruited more than 1,000 patients in that study, and we had defined from the beginning a sample size. The sample size was small because incidence of SUDEP is limited, and also because what we were interested in delineating was a risk factor that could really help us better predicting SUDEP. So, you know, if you find an association between a given biomarker and SUDEP, that will require 200 SUDEP to be demonstrated, this biomarker is likely to be associated with a very small odds ratio and likely not to be helpful in clinical practice. On the contrary, if you can make such a hypothesis that you will demonstrate an association in that case between periictal hypoxemia and SUDEP in a very small sample, well, then this is likely to be a very useful and predictive risk factor. So that was the choice we made. Eventually, the target was 18 SUDEP because we knew we wouldn't have interpretable SpO2 data in all our patients for a number of reasons, artifact, and so forth. The analysis was performed using 4 control per case, matched on the Epilepsy Center and data of inclusion, and using a so-called conditional logistic regression model. So the study was much longer than we had anticipated because it took more time to get 18 SUDEP. And that's because the incidence proved lower than what we thought it will be in that specific population. But eventually we get this number. we get this number. And as you see, as usual, most of the patient died at home or in a hotel room in an epilepsy institution, one each. Most were found in the bed. And when we had the information, the majority were prone. Now, that's the main result. And the main result shall be of interest for you and your epilepsy surgery program, because not only we confirm what we already knew, that the GTCS and nocturnal seizure were risk factor, but we found that the main risk factor in that population was an extratemporal epileptogenic zone, and more specifically, a frontal or perisylvian epileptogenic zone. And you can see in the first multivariate model that we can even get some odd ratio of 1 in 23, which is really huge. And of course, with a very large confidence interval, because we have a small sample. But potentially that means that this could really be one major risk factor that has not been clearly identified so far. Why will frontal and perisylvian epilepsy at higher risk of SUDEP? Well, we have a number of potential explanations. More likely to suffer from GTCS, but in our study, actually, we control for the frequency of GTCS. More nocturnal seizure in frontal and perisylvian epilepsy, but here again, we control for that additional factor in our analysis. And we also know that frontal preocular insular seizure can promote some respiratory disorder, in particular obstructive apnea and laryngospasm. And finally, the insula in particular is a primary component of the central autonomic network. Sam Latu has reported 2 cases that were operated in the insula with postoperative insular damage and later died of a SUDEP. It's just 2 case report, but we have similar experience. And even though it has not been clearly reported so far, in fact, there's a number of elements suggesting that insular epilepsy at high risk of SUDEP. This is a 2 patient reported by Sam and Nuria Lacque. So, conclusion on the risk factor: the risk of SUDEP vary widely across epilepsy. One can say between 2 and 200 per 100,000 patients per year. Mostly occurring at night in persons sleeping alone, found in their bed in the prone position, with the main risk factor being GTCS, nocturnal seizure, not sharing bedroom, lack of compliance to anti-seizure medication, but also perisylvian and frontal epileptogenic zone. In the frontal, I must say we had a trend towards central epilepsy in particular. So we move to pathophysiology, and just to make that transition, showing you again this region where I'm living above the lake of Geneva and close to the Alps, as you can see, even more beautiful in spring. Another study that we've done some time ago that has been important in the field because it compiled all the recorded SUDEP that occurred in EMU that were available at that time, at the so-called Mortimer study. So overall, we had 11 SUDEP that were monitored, and all zoos followed GTCS. Interestingly, almost half of them, almost half of those patients did not suffer GTCS usually. And in those half, 63% of the complete withdrawal of anti-seizure medication. So that's just some insight in the risk of suffering a SUDEP in hospital, which might be promoted in patients not suffering from GTCS with a complete ISM withdrawal. Most of them occurred at night in the prone position as usual. The most remarkable finding is that in none of those SUDEP was there an intervention of a nurse or anyone else within certain minutes after the end of the seizure. In contrast, in the same study, we had 7 so-called near SUDEP, that is a cardiorespiratory arrest, but eventually that was non-fatal and that benefited from a resuscitation. There was some difference. Only a minority occurred at night. They were never prone because, typically someone also turned the patient on the side. And most importantly, CPR was always started within 3 minutes. So that gives us a range of when you're likely to resuscitate a patient after a cardiorespiratory arrest following a seizure, including a GTCS, and where it's unlikely to be successful. Between 3 and 13 minutes, we don't know. Maybe it will still possible to save a patient within 5 minutes or 8 minutes, but we just don't know. Now, I'm going to show you a seizure recorded in the exact same circumstances as the one we had in Mortimus, except the patient did not die, luckily, and that's why I'm allowed to show it to you. It's at night. It's a focal to bilateral tonic-clonic seizure. The patient turned prone, and there's no intervention. So luckily, this patient did not die. Why some patient will die in such circumstances and other not, I cannot tell you. There might be a number of contributing factors, but it's just to show you the physical sequence of what has led to SUDEP in most of the cases that were recorded. Now, in Mortimus, we could look at respiration and heart rate, in particular in the postictal phase. And the first observation is that patient were still breathing and the heart was still beating at the end of the seizure, always. There were never a cardiorespiratory arrest immediately at the end of the GTCS. But then they first stopped breathing, and then there was a bradycardia and a systole. There were different patterns, but it was always in this order. And also, here you see 1 line per patient who suffered a SUDEP in the EMU. The first apnea was recorded within the first 3 minutes postictal. It occurred between 30 seconds and 3 minutes, most often in a relatively abrupt way. So, this is something specific. The patient is having a seizure. Okay, during the tonic phase of the GTCS, it doesn't breathe by definition, but then during the clonic phase, there will be a natural diaphragmatic movement due to the clonic movement. And then at the end of the seizure, the patient is breathing. Maybe it's not effective, but it's breathing always. And then for some reason, after at least 30 seconds, maximum 3 minutes, an apnea is occurring. So we have some hypotheses, and it's completely speculative at the moment. And one hypothesis is that at some point there is an additional factor producing the apnea. One possibility could be the release of some inhibitory neurotransmitter that are known to be released by the central nervous system, probably to counteract the seizure, help terminating the seizure. One of them is adenosine. Another could be endogenous opiate. And one hypothesis is that we're facing what I could call an endogenous overdose, where this protective mechanism might overshoot its primary objective. And maybe it needs the patient to be already quite hypoxemic to result in such an impact. That's where the prone position in particular could have an important role by aggravating the hypoxemia already resulting from the respiratory arrest during the tonic phase. But again, all that is speculative. We have undertook that work with Adam Strelniks from Frankfurt. Is not yet published, but we have compared his multi-center series looking at the prone position in GTCF in the MU to that of Mortimus. And to make a long story short, the fact of being prone at the end of a seizure, when comparing those series, seems to result again in a huge odds ratio, over 200, in the risk of dying of a SUDEP. So, to me, this prone position is a major factor in the event leading to SUDEP. It's not mandatory, we know that, in the same way that seizure is not mandatory. So there might be different mechanism and pathway to SUDEP, but in the majority of cases, it seems to be maybe the most important contributing factor. And so, of course, it makes the search for any other biomarker very difficult because of this prevalent role. And here we're in a kind of, catastrophic theory, as we can observe in plane crash, where it's always a different story with multiple mechanism, multiple event or deficiency concurring to eventually the plane crash. So I just mentioned previously that sometimes SUDEP is not following a seizure. And in particular, there were 3 cases recorded in hospital, again reported by Sam, that illustrated this situation, even though I must say that those 3 cases are complex to understand. And from what I remember, at least 2 of them were post-operative after some kind of a neurosurgical procedure. And there's some unresolved question of the potential for brain edema that could have slowly developed and resulted in respiration to stop first, here again, and then terminal asystole. Now, we mentioned apnea. Apnea preceding asystole, both in seizure-triggered SUDEP and those non-related to a SUDEP. For those following a GCS, then the question is, what kind of apnea are we dealing with? Is it essential apnea? That what will result from the release of adenosine or endogenous opiate, supposedly? Or is it obstructive? Definitely in the case of the front position contributing factor, but maybe also laryngospasm. And at the moment, we believe that both mechanisms are involved, but we don't know to which proportion. And the same discussion has took place in animal model of SUDEP, primarily a rodent animal model, with Mark Stewart bringing interesting data, suggesting that the obstructive part could play an important role. And I do concur with his conclusion. This is an animal model again, just to illustrate the role of adenosine. So when you increase the concentration of adenosine in the brain by injecting antagonist of its catabolic or metabolic pathways, you first inhibit the development of epilepsy. We know that adenosine has some anti-epileptic properties. But paradoxically, if you move the animal model further, then you will increase the risk of SUDEP with more adenosine. And you can antagonize this effect with caffeine, which is an interesting observation for potential preventive measure in human. Now, for the last 10 years, there has been also this nice theory that the central component of apnea could be promoted by a spreading depolarization in the brainstem. And this has been shown in several animal models, transgenic mice harboring mutation found in human, like those from the Dravet syndrome, as well as others. And I'm not going to go into the detail of those experiments, but I just want to show that when you look closely at the result from this paper, it appeared that apnea start here. You see, this is respiration. So respiration stop here. And spreading depolarization, as can be illustrated by brainstem DC, really start there. It's well known that hypoxia promotes spreading depolarization, so it makes sense that it will follow apnea. But of course, that leads to a different interpretation than that proposed by the other, that spreading depolarization will be the primary factor leading to apnea. And another paper from another group on another type of transgenic mice also reported spreading depolarization in the brainstem. But here again, when you look closely at the published data, you see that apnea occurred here. And the occurrence of spreading depolarization as showed by MRI in that case with diffusion-weighted imaging only started there. That doesn't mean that spreading depolarization wouldn't be a contributing factor. In fact, rather it could explain a kind of vicious circle where apnea will first develop in this model, promote spreading depolarization in the brainstem that will then further sustain the respiratory disorder. Now, there has been a search for other biological contributing factor in the brainstem of patient died of a SUDEP. This is one of the study. I, again, don't want to spend too much time on this. It performed a number of proteomic study and find that different metabolic pathway were different in patient who died of a SUDEP as compared to patient who died of a other cause than SUDEP, accidental or else, in person with epilepsy or in non-epilepsy patient. Here again, however, the limitation I mentioned previously with respect to the autonomic biomarkers remain the same. What could be due to GTCS and the fact that in such seizure, the discharge is propagating to the brainstem, and what could be potentially causal to SUDEP? We really don't know. So, second conclusion, before we move to the last part on prevention, pathophysiology, well, SUDEP is primarily triggered by a convulsive seizure in most cases, but not all, followed by a postictal respiratory distress and terminal apnea, obstructive, central, probably both, to which proportion each, we don't know. The prone position definitely is playing a very important role. At the moment, we cannot elaborate further on the cellular and molecular abnormality in the brainstem and other part of the central autonomic network that might promote SUDEP. Most animal models demonstrate a comparable sequence of the event in terms of apnea, and then cardiac arrest. But I must say that the clinical sequence remains a little bit different, and often apnea will start during the seizure, and in particular during a tonic seizure, not in the postictal phase. And that's quite a significant difference in my view. And those models also suggest the role of brainstem serotoninergic dysfunction and spreading depolarization. This is the same region I'm living in Fall, and we'll now discuss prevention. So the first aspect of prevention is nocturnal supervision. There has been this Cochrane study that conclude that very low quality evidence support the preventive impact of nocturnal supervision against SUDEP. But I think we all understand it makes so much sense with respect to all what we discussed previously, that if you can be aware of the occurrence of a GTCS at night and have immediate intervention, let's say within the first 3 minutes postictal, you're likely to prevent a SUDEP. So that led to the use of wearable device for seizure detection, and you know that several such devices are available, very much reliable for detecting GTCS at night in particular. But at the moment, we also must be clear that there's no evidence that using this device will reduce the risk of SUDEP, that it increase the proportion, the number of intervention after GTCS, or that it reduce the delay after the alarm. Again, you might say, well, you know, it's trivial. Maybe there's no high-level evidence, but it should be the case. One issue here is that in patient not living alone, the family might often be aware of the occurrence of a SUDEP without alarm, definitely if they share the same bedroom, if it's a spouse in particular, but maybe also if it's just another room in the same flat. And so that the alarm, you know, might not have such an impact. And on the contrary, if the patient is living alone, the caregiver will probably never have the time to come and have a timely intervention. But in fact, there might be a mitigating factor in this case. And Mortimer Ryvlin, I didn't mention that the majority of patients who died of a SUDEP in EMU are several SUDEP, or at least two in the same night, many of them. And maybe the repetition of GTCS within a relatively short period of time, it's not a status epilepticus, but still, you know, it's within 5-6 hours. Maybe this is an aggravating factor. And then the alarm could allow the caregiver to intervene after the first one, at least, and find a way to avoid the second one. Anyway, the conclusion at the time is that it is uncertain whether the detection alarm results in a meaningful clinical outcome, and further research is needed. I think that the most important conclusion. We need to perform more research to demonstrate the utility of such device. Now, what about anti-seizure medication? We performed that systematic review some years ago, trying to sort out how many SUDEP were reported in randomized clinical trial of add-on anti-seizure medication in drug-resistant epilepsy. Because it's rare, you will have from 0 to maybe 2 or 3 SUDEP in any such randomized control trial. So at the level of one trial, it's impossible to demonstrate anything. But when you pool all those studies together, more than 100 in that case, well, we found a very significant impact. As you see, there was a 7-fold lower risk of SUDEP when the patient was receiving a new ISM on top of his regular treatment, as compared to receiving a placebo on top of its regular treatment. what does that, how does this translate into clinical practice? Most of those trials are for 3 months only. And you know that often there is indeed a clear reduction in seizure frequency for a few weeks with the new drugs in many patients, and then this impact decreased over time. So if we would like to implement this finding into clinical practice, that will mean add another drug every 3 months, which obviously we cannot do. But I think the message is that in patients at high risk of SUDEP, probably being more aggressive on treatment is likely to decrease the risk of SUDEP. And that's maybe something we need to keep in mind, where sometimes we're a little bit desperate in trying a new drug because the patient has failed so many in the past, and we believe we're exposing it primarily to side effect with very little chance to make him seizure-free. Maybe very little chance to make him seizure-free, but maybe some chance to reduce the risk of SUDEP, maybe. This conclusion is supported by this famous Swedish case control study, national case control study, where it was shown that polytherapy was better than monotherapy and definitely better than having no drugs in reducing the risk of SUDEP. And the fact of non-being adherent to treatment, as I already mentioned, is a clear risk factor. Looking at individual drugs so far do not show any ISM that will be a high risk. In that same study, there was some suggestion that maybe levetiracetam could be more protective than others, but that will need to be confirmed. Now, more recently, we have some publication with fenfluramine in Dravet syndrome, where the risk of SUDEP is huge, that seems to suggest that the risk of SUDEP might decrease with the use of fenfluramine. But this comparison that has been published here, we must be very cautious, because those historical control might not be comparable to the current stage of treatment of Dravet syndrome, regardless of using fenfluramine or not. Nevertheless, it's interesting, in particular also because we'll soon have another drug acting on 5-HT2C receptor developed for epilepsy that could have maybe a specific protective role for SUDEP due to its action in the brainstem. What about the surgical treatment? And I will finish on this. Well, again, the Swedish nationwide case control study suggests that VNS could be protective against SUDEP, as you can see here. And we have made similar observation in the past, looking at this large population of US patients that were treated with VNS. Here we don't have control. So the only thing we could look at is how SUDEP rate evolved in a large cohort of patients who receive VNS. So we compared the rate of SUDEP after 1, 2, 3, and so forth, years of VNS. And you can see this trend into a decreased rate of SUDEP until year 9. And that trend was very significant. Of course, there could be multiple explanations to this trend, not necessarily VNS. It could be changed in other ways. Patients were managed in that cohort. So that's very low level evidence. What about surgery? Well, there has been contradictory findings being reported in different series. And this is why Sylvain and myself, we undertook this meta-analysis recently. And pulling all the data available together, it suggests that epilepsy surgery might indeed be protective against SUDEP. And maybe in particular, if we can cure patients with perisylvian and frontal epilepsy. So in conclusion, while there's no high level evidence available to support that any intervention against SUDEP is effective, but because we want to do as much as we can to protect our patient nowadays, while not having access to those high-level evidence, I think it's reasonable to advocate for, first of all, informing patient and families about SUDEP and its risk factor. Bereaved family are very, very, very demanding on us neurologists, epileptologists to provide more information sooner. Many of them will tell you that if they had received that information, they possibly could have found a way to mitigate the risk and could have saved their loved one. And I think in many cases it's true. Promote nocturnal supervision, seizure detecting device in person with nocturnal GTCS. Despite the lack of evidence, to me, it's very fair to propose this systematically, and adopt a more aggressive therapeutic strategy in person with uncontrolled GTCS, whether it's trying a new drug, whether it's offering VNS or offering epilepsy surgery. Thank you very much for your attention, and I'm looking for your question.
Thank you so much, Dr. Ryvlin. That was fantastic. For people on Zoom, please put your questions in the Q&A. We'll start with the group in person here. Any questions? Yes, Elliot, go ahead.
Do people with pre-existing sleep apnea or like obesity risk for OSA, are they at higher risk for SUDEP?
Were you able to hear that, Dr. Ryvlin?
Yeah, that's a very good question. So actually, I didn't show you that, but in the paper that we will publish soon on the REPONSE study, we integrated this clinical information. And at least in the univariate analysis, both the BMI, high BMI, and indication or risk for sleep apnea syndrome, the SIS-DQ score, were predictive of the risk of SUDEP.
Thank you.
Excellent.
But I cannot tell you for the multivariate analysis so far because the results are pending for the specific risk factor.
Any other questions? I have one question, Dr. Ryvlin. What do you think? That was a very interesting finding that you mentioned that the risk was higher in extratemporal epileptogenic zones. Do you think it's because they're more likely to have generalized convulsions because of the proximity to the peridolandal cortex?
So as I mentioned, yes, it's likely that they might promote both GTCS and nocturnal seizure. We know that for frontal lobe epilepsy and insular epilepsy.
Right.
But in the multivariate analysis, it seemed that the localization of the epileptogenic zone remain even when you include those two elements, and in fact, largely prevails in terms of effect on those two types of risk factor. So I think there's something else. In particular, their impact on both the autonomic system that might get more fragile in patient, and in particular that controlling respiration.
I see.
But also the motor activity. And let me elaborate on this. That's something we're still exploring, but it seemed that the fact of having a focal motor seizure within the GTCS might be an aggravating factor. And possibly, again, because it might further fragilize the motor component of respiration, maybe our body movement in general, and will somehow increase the risk that the patient by the end of the seizure, especially if it's prone, will not be able to cope with this postictal immobility and coma, if you wish. And there might be other reasons that we ignore.
I see. Thank you. I think there's a few questions in the chat. Question one is there any difference in risk of SUDEP in patients with normal MRI and those with a structural lesion?
The presence of an MRI lesion was not found to have an important role in our study. But if you take all lesions together, including hippocampal sclerosis, then it appears to be protective.
I see.
But of course, it might be protective because if you include hippocampal sclerosis, then you will have a majority of temporal lobe epilepsy.
Right.
It appears to be much less likely to result in SUDEP.
Okay. Second question is, does having no seizure control after epilepsy surgery increase the chance of having SUDEP, or poor seizure control after surgery? Does that increase the risk?
Yes. So, in some of the older study, and that of Mike Sperling in particular in the past, it showed that when you take patient who underwent temporal lobe epilepsy surgery, there was a major difference in the risk of SUDEP in the group that was controlled by surgery and the group that was not controlled by surgery. But here, of course, there might also be a bias because, as you can expect, we're not talking about the same epileptogenic zone in these two populations.
Right.
If the patient that underwent the same type of surgery have different outcome, it's primarily because they have different epileptogenic zone, and you might suspect that the temporal lobe epilepsy surgery case that were not controlled are likely to suffer what we call temporal plus epileptogenic zone that again will extend to the perisylvian region and the insula.
Right. Okay. And one more question here is there any data about pharmacoresistant genetic generalized epilepsies and the risk of SUDEP or idiopathic generalized epilepsies?
Very little, actually. Very little. This is typically the population you don't record in the EMU.
Yeah.
So there has been much less research trying to better understand or capture biomarkers to this purpose. So basically, the risk of SUDEP seems to be lower than in focal epilepsy if they have idiopathic generalized epilepsy. Whereas, on the contrary, if we're talking about epilepsy like Lennox-Gastaut syndrome or Dravet syndrome, with neurodevelopment disorder, here the risk appeared to be, in fact, much higher. So we need to distinguish the genetic cause into those that are idiopathic and those with neurodevelopmental disorder, and then the risk is really divergent in those two scenarios.
Okay. Well, thank you so much, Dr. Ryvlin, for your time. Oh, there's one more question.
Yeah, last one. In people who have suffered SUDEP, is there a relationship to the SUDEP episode and the timing of their last GTC? Are like they higher risk of SUDEP after, close to their last nocturnal GTC, or can it happen like any time? Do we know that?
I don't think we have that information. I'm trying to remember whether I've saw any paper. That's a very relevant question, but I'm not sure we do have this information. But to further elaborate on this important issue for 1 second, on the one hand, the frequency of GTCS is a risk factor, and we can understand GTCS plays such an important role that the more frequent, the higher the risk. But it might be a kind of U-curve, because it's also seemed that when you didn't have GTCS for a long time, and suddenly you have one, it could be after successful epilepsy surgery and the decision to withdraw completely treatment, or even after people who were on drugs only and for some reason reduce or stop drug, lack of compliance, whatever. Well, it seemed that there is also some specific risk here, like if the brain was less able to cope with such an emergent GTCS than when he has a regular one. So yeah, I'm speculating here, but I think we do have those observations where sometime the SUDEP will occur after one GTCS in a patient didn't have any for years.
Thank you.
Okay. Well, thank you so much, Dr. Ryvlin. That was a fantastic lecture. Thank you for your time.
You're welcome. Thank you. Have a
Thank you.
great day.
Hope to
Bye-bye.
have you in person sometimes.
Bye.